Afternoon, everybody. My name's Alexander Crichton. I'm an SD5 vascular registrar and I'm out of Corroborated. I'm currently doing a PhD. These are our disclosures. We know that imaging patients with CLTI, particularly below the knee, is challenging. It's all too common that we see a problem like this, where we do a CT scan, we focus in on the tibial vessels, and let's say we look at the AT here, and it's practically non-diagnostic, even in the proximal vessels, and this is because of poor resolution and calcium artifact. And the problem is our alternatives, such as contrast MRI or ultrasound or DSA, only image from patent to patent. But it's what makes up the occlusion when we're talking about endovascular surgery that drives immediate technical failure. And if we look at the trials, Basel 1, Basel 2, Best CLI, immediate technical failure is almost completely unchanged at 13 to 20%. That's 2 to 3 decades of randomized controlled trials. But we believe we have a solution. UTE MRI is a non-contrast MRI technique. It can be done on a 3 Tesla MRI, and it can unlock our understanding of what makes up the occlusion and its relationship with immediate technical failure. And so we put it to the test in an amputated limb model. We use amputated limbs from patients who've reached the end of the road for their limb, and we recruit them into our study, and they undergo this 3 Tesla non-contrast MRI technique. And then we do a crossing experiment once we have that understanding of what the plaque morphology is. Specifically, we're looking at high-grade stenoses and total occlusions as well, so anything less than that is excluded. The reason we've chosen crossing as our most important is because consistently this is the most important and commonest cause of immediate technical failure. So we do this in a hybrid OR done by a vascular surgeon scientist. And then once we've done that, we harvest out the vessels, and this allows us to histologically validate this model. So this is a 50-patient study. We're 39 in. Each limb usually gives us more than one vessel, so we've done 67 crossing experiments. We've seen a 3-to-1 ratio of hard versus soft lesions, hard being problematic lesions compared to soft not being so problematic. And this is what we saw, is that MRI-defined hard lesions are significantly more likely to be non-crossable. But to you as a vascular surgeon, what does this mean? Well, here's a perfect example. We can see here that this patient has a distal anterior tibial occlusion, but this DSA gives you no more information about how easy or how difficult this case is going to be. This MRI scan gives us that information. When you see a central blue, that means that this is a soft lesion. So we can see that there's medial calcification here, but this will be easily crossable. This is not going to be a challenging case from the point of view of immediate technical failure. Now, when we compare this to this type of lesion, when you see purple in the center, that usually means that it's hard contents. And actually, we're able to break down specific contents of the lumen. So we can see here that this is a calcific predominantly total occlusion. This is going to be really challenging to cross. But finally, we are now able to identify this. This is collagenous arterial disease. And this is important to you because it is invisible to you with conventional imaging. It'll just look like this on a DSA. You'll see a short occlusion, and then you can't make any sense as to, again, how easy or how challenging is this case going to be. Again, purple means hard, but we are able to go a step further. This is important to you as well because it accounts for 30% of the hard lesions, and it behaves almost identically to calcific artery disease. So now we're able to validate this model because we harvest every vessel that we do this experiment on. And what we can see is that the MRI is linking really nicely with the histology. So the yellow outline is showing you the calcium. This is a 3mm vessel. And the green outline is showing you the lumen, which is 1mm at best. This is a distal vessel. We are able to give you this information now with this technique. The other advantage of using histological evaluation is you can see the amount of injury that you're causing. So on the, I have to think left and right here. On my right, your left, yeah, good thing I'm out of training. You can see a calcific total occlusion. And you can see that we've gone into a subintimal plane and then we've caused a perforation. This is a hard calcific lesion. We compare this to a soft lesion. We can see that star is showing you the catheter imprint. So we've gone straight down the lumen. But The arrow is pointing to intimal injury. So even just with wire crossing in soft lesions, we were seeing some form of vessel wall injury in 50% of cases. It was higher in hard lesions, over 80%. So we've identified the problem. We are validating the model, and now we need to push the science forward, because otherwise we're going to keep on running into this problem. And we've worked with Baylis Medical Technologies on their radiofrequency power wire. This lesion is hard, it is mixed collagen and calcium, and you can see that we have now been able to pass through. That star is showing you the catheter imprint. This was previously non-crossable. So the take-home messages are that we need to make advances in immediate technical failure, and we need imaging that can guide us and identify these lesions that are at high risk. And ultimately, I believe that we need to integrate this into our clinical practice and integrate this into device development before you receive these kind of devices, so they're safer practice and so that we can reduce endovascular failure. That's all from me, everyone. Thank you very much. Are there any questions?
Questions?
So my vascular technologists in the vascular lab give me all this information. Why am I going to spend millions on a 3 Tesla MR?
So I think that having an anatomical map that tells you all of the plaque morphology and its full relationship to the vessel, that eventually I think we could do image fusion with, will be important to you in the future. I also think that ultrasound is not going to show you those collagenous hard lesions. So that's 30% of your caseload already.
It does. I get that report from them every week.
That you've got.
So I can test the actual validity of doing it with an MR when you can get that information.
I need to talk to your technologist then, because. Okay.
Paddy.
Two questions really. One is, are there other things at play here? Are there things that the eye can't see within the scan that are actually more important than what you're seeing? Radiomics and those sorts of things. And have you looked at that to see whether it has an influence and you can correlate it with your outcomes? And secondly, what about longer term failure? You've just shown, ability to cross and those sorts of things, but actually is it also, have you looked at any work that tells you whether this can predict longer term outcomes?
So I'll tackle the second point first. So we now have an NIH funded study running now, and that is looking at patients who are going for procedures and they are undergoing this MRI. So we will be able to give you real patient data that shows you the relationship with not just immediate technical failure, but short-term, medium-term, and long-term outcomes. We have some preliminary data showing that these lesions are associated with short-term failure. And what we're also doing is this MRI technique allows us to evaluate the vessel wall after treatment. So we are doing follow-up MRIs on these patients to see at a vessel level and histological level what is happening based on what treatment you're giving. Because I think that we don't really know what the right vessel preparation treatments are based on plaque morphology, and I think we do need that information. So your first point, can you clarify that a bit more, please?
The first point was actually using the scans, because what you're showing is what you can see, but actually, is there more biology going on in the vessel wall that you can look at from the point of view of radiomics and that sort of thing that might be able to actually give us a bit more information, actually really tell us what's going on?
So we've done AI work, and we're also doing transcriptomic work. So transcriptomics gives us single cell evaluation. And the idea is that we've got to work that model down. We need a lot of data. So we've been doing that to tell us about things like medial calcification. So medial calcification is actually probably a progressive disease that starts with little areas of calcification that then becomes circumferential. And the idea would be, could you identify certain genetic markers that would allow you to stop that process? You could then form some form of target treatment. So we're currently doing that with our 9.40 MRI. That is ex vivo, and then we're going to work that model down to be able to do it hopefully with 3 Tesla. So it is something that we're moving towards, but yeah, that's going to need a lot of data.
So time just for one more question. Professor Chetta?
Correct me if I'm wrong, but you were doing interventions on cadaveric legs, essentially.
Correct.
Do you think it's a big leap of faith to propose what happens in a cadaveric leg is what would happen in a living leg? So if You know, if a leg's been dead for a day, is it easier to perforate the vessel than with a, you know, a living leg?
So I don't think it is, and these cases are all done by a vascular surgeon scientist. Again, we have our NIH study as well running, so we'll be able to provide you real patient data and the associations of that with this MRI technique in the future. But from I don't have a number to give you, but I haven't seen. I guess you could consider yourself to be more aggressive, to be fair, I think, in an amputated limb setting. I don't think that's wrong.
Thank you.
Thanks, everyone.